Program Director at Cancer Support Community Arizona, and I'm pleased to be here today with Dr. Randy Kraft. Dr. Kraft, could you explain your role here at Cancer Treatment Centers of America?
Yes, I'm a plastic and reconstructive surgeon here at Cancer Treatment Centers of America, and have been on staff for a little over 3 years now.
Wonderful. So today we're talking about body image after cancer, a hot topic because a lot of people experience sort of body image types of issues. So I know one thing that has come up often is, you know, how do you work on, what are some options that people have after surgeries that they might have to help them feel better about their body image?
Mm-hmm. So for me, body image isn't one of the things I talk about. It is the reason that I exist here. I'm not a cancer doctor, so I don't treat cancer. So the issues with body image in patients with cancer is the only reason I have a job. So it is kind of the beginning and end of most conversations I have with patients. The most common space that we talk about that is obviously in breast cancer, because it's a very common disease that happens. So breast reconstruction is one of the most common things that we deal with. There are many options for breast reconstruction today, including with implant-based, but also using your body's own tissues, which long-term can have a more natural feel to it and not require that maintenance that implants do. But I also deal with this in the area of head and neck reconstruction or body. It's all fair game. So there are many areas of the body where this topic comes up.
Sure. And so as far as, you know, some of those types of surgeries that you perform, are those covered through insurance as part of cancer treatment, or how does that work for patients?
That's a great question, because sometimes people think that the body image issues is elective, or, you know, is my insurance going to pay for this? And that can be an additional unfortunate stressor for people who are already dealing with a cancer diagnosis. Everything that the treatment entails, and then they have to wonder, what's my financial responsibility for this? Or is it okay to worry about this, you know, as something that's important to me? And then is someone going to pay for it, or am I going to be responsible? Makes it even worse. So in general, especially in breast cancer reconstruction, it's virtually always paid for under almost every insurance plan, and that's because of a federal law that had been passed several years ago. There are some exceptions to that. There are a few church-based insurance plans that aren't federally mandated to provide that coverage, but that is very much the exception.
Okay. And then is there a period of time that they have to have it done in order for it to be considered part of their cancer care? How does that look? How does that work?
That's a great question, because the other thing with body image and people's perception, some women choose, for breast cancer example, again, not to have reconstruction right away, and that's a valid choice for a lot of women. There are a lot of reasons for that. It could be because of where they are in their life personally, because of other health issues, and they just opt not to deal with that at the time of their cancer treatment. Those women sometimes feel that, well, you know, I kind of missed the boat on that. You know, insurance won't cover it now because it's not part of my acute treatment, and that's just not true. Reconstruction is an option for women who had their cancer diagnosed yesterday or 10 years ago. I see a lot of women who went without reconstruction for many years, and where it wasn't a priority to them before, it now has become a priority. And that is still an option for insurance to cover, and it's still a very valid thing to address at a cancer center, even if all your acute cancer care is done and a thing in the past.
Sure. So how would one, does somebody have to go through their doctor in order to get referred to that piece? Or let's say it's been a good length of time, are they able to seek that choice out on their own and come see someone like you to be able to do that type of surgery?
Yeah. That's a great point. I see women from both pathways. Sometimes women will see an ad, or, you know, look in the phone book, or I guess now that doesn't happen.
Right.
Google would be the way that they find that. And they call our hospital directly, and we're happy to see patients who refer themselves. Sometimes, depending on patients' insurance plans or what their source of medical information is, sometimes they come to us as a referral from their primary care doctor. I've had dermatologists send patients to me. It's whatever physician encounter where they learn that that patient has that need, they refer them to us, but it's not always necessary. So patient, you know, owning their own health care and making that referral themselves is a very welcome pathway too.
And I know a lot about, you know, body image is really, you know, obviously the physical side of it, but also obviously our perception of that. Is there any kind of process that patients go through, you know, prior to surgery, or different members of the team who might help them also with coping with some of the body changes they may have had?
Yeah, it takes a village. So even though that is my only job here as body image, I'm not the only one who has that job. And so we all bring different pieces to that puzzle. We have mind-body counselors here who talk to patients about, how do I cope with my body image example. And sometimes it's not even the surgery itself, it's I have, breast disease or this diagnosis, and something that was a very important part of my body they now see as kind of, for lack of a better word, the enemy, or something that is working against them. So even that takes a lot of coping and discussion. And then that evolves as surgery and removing that part of the tissue. It's a whole different conversation, but all of it's on the same spectrum of how you feel about your body during this treatment. And it's a journey. It's not the same on day one as it is toward the end. So there's a lot of members on our team that help with that, be that the mind-body physicians, the nutritionists, psychiatry, everyone that we can pull in to help with this, we all address it in one way or the other.
That's great, because it sounds like you're really looking at the whole patient.
Yes, because it's not just one piece of it that matters. It's multifactorial. There are a lot of things and it's different for every woman or person with cancer.
Right.
What that's going to bother them about this experience is not cookie cutter or never the same. So it really takes a dialogue with that patient. So for me, in a new consult that could be an hour, the majority of that time isn't talked about the technical or surgical aspects. That's a pretty straightforward conversation. The majority of that time is talking about that individual's goals, like what do you hope to achieve, what bothers you. It's a very intimate conversation. I mean, I spend a lot of time with these women in particular, and I tell them, you're going to see me more than any of your cancer doctors, hands down, as part of this process.
Got it. And so when you do those consultations, do you meet just with a person diagnosed? Is family welcome to be part of that discussion? I know sometimes that's, body image and even sexuality really go hand in hand, especially when we're talking about women with breast cancer. Is that part of the process? How does that work?
That's a great question. It works different every time. So part of it for me is getting to know that individual and getting a feel for kind of where they are and where they are with their partner and where they are with their family. Sometimes I'll walk in the room and a woman is there with, sister, mother, children. Other times it's just her partner. Other times it's a combination of all above, or just a trusted friend, or alone. And learning to navigate where they are with that space and the comfort level of getting the medical information and the information about surgery, and then teasing out what they're most comfortable with, discussing the issues of intimacy and sexuality and when to have that conversation. So part of it is judgment. I'm not necessarily going to have that conversation in a cookie cutter fashion with everyone who's in the room, because that's just not productive for anyone. Which means for virtually every patient, they see me more than once. And so I always try to have an opportunity where we're able to have that dialogue individually. And then if they want their partner in there to express their concerns and get education, then we invite them into that as well. But it really is driven by the patient, and there's no one way to successfully do that.
Got it. Now, I know you mentioned a lot women with breast cancer. I think that's one of the areas. And then head and neck. Is there any other kinds of typical types of cancer people might see someone like yourself for?
Pretty much anything. So, I mean, skin cancer is common. The head and neck cancer we discuss. I also do perineal reconstruction or part of the genital area reconstruction. So obviously all those things are very personally and intimately tied to people's body image. And I can't think of part of the body that I haven't operated on for reconstruction. And you can't say just because it's on, it's just their arm or their hand, it's not going to have a significant impact on them. So it really is everywhere. It could be anything and anywhere for anyone.
Wow. Well, thank you so much for joining us today. Again, I'm Tracy. I'm with the Cancer Support Community Arizona. Dr. Randy Kraft here with Cancer Treatment Centers of America. And it sounds like there's lots of options out there for people who are experiencing body image issues after cancer treatment. So
Absolutely. Thank you.